earlier on, which is cholestatic type of jaundice. And there, what you would do is number 3, you would do imaging. You would do imaging, starting maybe with something as simple as ultrasound, to check out the diameter of the common bile duct. Yeah. And when you look at the common duct, you end up with 2 groups of patients. The one where it's normal, less than 1 centimeter in diameter, and the one where it's enlarged, more than 1 centimeter in diameter. And if it's enlarged, then you know your cholestasis is extrahepatic. And if it's extrahepatic, well, then your big story is probably gallstones, whether they're bilirubinate or whether they're lipid, pigmented or not, or otherwise it could be a cancer, like a pancreatic cancer, head of the pancreas. So maybe check for CA 19.9 for pancreatic cancer. Or otherwise it could be other reason, but these would be big one to have an enlarged common duct. If it's normal, then it would have to be intrahepatic cholestasis. And there your best bet is going to be to check for antibodies. So check for AMAs, because if it's positive, it's PBC. If it's negative, it's not PBC. So what could it be if it's not PBC? So CA, you could be looking as but CA is not a specific of pancreatic cancer. For example, you measure CA in colon cancer also, but it's true, it's also elevated, carcinoembryonic antigen. Is that okay, Zaya? If it's not PBC, then look what you can do now. Let me blow this up. If it's not PBC, then check for anchor, and it's either going to be anchor positive or not. But I mean, anchor positive definitely would tell you that it's primary sclerosing cholangitis, for instance. And if it's anchor negative, you're going to have to find other reasons for having cholestatic jaundice. So I'll give you one. So example, how about this? What is GVH? CA there is elevated or is measured elevated in a number of visceral malignancies. For example, GI malignancies have elevated CA also. So a colon cancer can be looked at with CA as a marker to monitor maybe some regression with treatment or recurrence in spite of treatment. Is that okay? Where CA 19.9, that's more classically associated with a pancreatic adenocarcinoma. So yeah, graft versus host disease, where there would be skin, biliary, and GI attacked by T cells in particular. Or otherwise, it could actually be hereditary once again, and that's what we're going to finish with, because I see it's already 11:02. Hereditary syndromes with biliary excretion, so with impaired excretion. And there, what are going to be the two? Well, if there is black pigmentation of the liver, what would you tell me? then it's called Dubin-Johnson syndrome. Dubin-Johnson syndrome. And that's autosomal recessive, and it's a transporter called MRP2. So multi-drug resistant protein number 2, that's defective. If, on the other hand, there is no black pigmentation, but still a cholestatic jaundice, then you know that it could be Rotor syndrome. And in Rotor syndrome, you have again an autosomal recessive disease, but this time it's the getting the bile, the bilirubin, into the canaliculi for excretion through a solute carrier protein that's called SLC for solute carrier 21A. In Dubin-Johnson, the MRP2, well, that's the one that would allow you to actually take it from the sinusoids back into the bile, and that's why it stays in the liver. The syndrome in the blood and then allows it to be excreted in the urine, but you don't see the black pigmentation. So there we go. That should give you a big workout that all started with checking bilirubin, checking the enzyme. If it's hepatic, checking the level of these enzymes. If they're very high, then checking the serology to kill those viral hepatitides. If it's not viral, then there were all kinds of diagnoses of exclusion that are rarer. Versus imaging the diameter of the common bile duct. If it's normal, it's intrahepatic, double check that it's not PBC by looking at AMA. If it's not, check for anchors, maybe it's PSC, or otherwise other reasons to have intrahepatic cholestasis, maybe the hereditary syndrome. If it's an enlarged common bile duct, well then something in the common duct is blocking the outflow, like gallstone, strictures, maybe a cancer that's compressing the common duct, like the head of the pancreas, or cholangiocarcinoma, an ampular vata, GI type of carcinoma. I hope you enjoy your 3 hours and you worked hard. Do you have any questions for me as I prepare this as a PDF?